All right, good morning, everyone. Thank you for your attention. My name is John Admire. I'm a chief resident in the department, and I have been asked to speak today, and I'm happy to be given the opportunity. I will be discussing perioperative planning. My title is Perioperative Planning, Evidence-Based Strategies for the General Surgery Patient. I have no financial disclosures this time. So I think in a topic as broad as this, it's best to at least have some goals and plans on what the discussion will entail. I would like to discuss our role in planning of an operation and the execution of that plan, namely elements that directly affect patient care, but that are not a portion of the technical aspect of the operation. While there's no way to include every element or answer every question on this topic, I wanted to address specific topics that seem to come up frequently in clinic or on the day of surgery that are sometimes met with shoulder shrugs and not much evidence, though evidence does exist. To outline my discussion, I've included 5 main points that I would like to discuss. What are our anesthesia colleagues looking for in their assessment on the day of surgery? What is an evidence-based approach to pre-op labs and imaging? What patients require preoperative risk stratification from a consultant? And I'm going to focus mostly on a cardiology consultation. What does the literature say regarding home medication modifications in the perioperative period? And what are care bundles? So to go hand in hand with that, I think it is worth discussing limitations. This talk will focus on patients that would be seen in a conventional community general surgery practice, such as hernia, soft tissue, breast, colorectal, etc. I will not specifically cover vascular, pediatric, transplant, cardiothoracic, or bariatric patients, though there may be some crossover with these different disciplines. Acute care situations will not specifically be discussed, as again, this is an elective care discussion. And again, this discussion is provided, is meant to discuss current guidelines and recommendations, but will not replace clinical judgment or certain case-specific perioperative planning scenarios. So, why do we ever order a test? It should be because the result will make a difference or potentially make a difference in patient care. As a caveat to this, the preoperative test ordered should help guide care and potentially mitigate risk to the patient. To this end, the ASA has developed practice advisories, which are readily accessible, to help guide care in a multitude of areas related to anesthesia and perioperative surgical care. The practice advisory was initially developed in 2001, published in 2002, and has been updated most recently in 2011 and then published in 2012. The advisory board at the most recent update was comprised of 234 ASA members and 72 board-certified anesthesia consultants. So just a word from their society. The practice advisories, developed by the ASA are not intended as standard guidelines, as standards, guidelines, or absolute requirements, and their use cannot guarantee any specific outcome. They may be adopted, modified, or rejected according to clinical needs and constraints, and are not intended to replace local policies. So, the ASA Practice Advisory defines the pre-anesthesia evaluation as the process of clinical assessment that precedes the surgery of anesthesia care. As the process of clinical assessment that precedes the delivery of anesthesia care for surgery and for non-surgical procedures. There are 3 elements. Data in this assessment may include the prior healthcare record, the H&P, and other testing done prior to the day of surgery or actually on the day of surgery. They are meant to address the following 3 points: discovery or identification of a disease that may direct anesthetic care, verification of an already known disease which may affect care, or formulation of plans and alternatives for anesthetic care. The slide reviews the level of evidence and the class of recommendation for a given test or intervention. As before, any test or evaluation ordered should be done with reasonable expectation that such test will result in benefit that exceeds potential adverse effects. To prepare the level of recommendation, it is helpful to have this chart that guides us to have some kind of idea of how strong the evidence is that points us towards a certain pathway in care. There are both classes of recommendations, that is to say an intervention is useful, or possibly harmful, all the way from levels 1 to 3. And the level of evidence includes levels A really to D, depending on the literature that you review. But A is the strongest level of evidence, where the decision is, or the recommendation, I should say, is based on several randomized control trials. And then it goes all the way down to level D, where it's essentially expert opinion based on experience, really. Regarding the pre-anesthesia evaluation, there is no controlled clinical trial that exists regarding the exact timing of that evaluation and its clinical impact. It is guided largely by expert opinion. For example, in our training at UT Health, we have the UPOMC clinic. And in essence, this gives the anesthesiologist an opportunity to assess a patient prior to actually going under general anesthesia and going under the surgeon's knife. It is ultimately left to the judgment of the surgeons, realistically, on who those patients, or on which patients should go to the UPOMC clinic preoperatively or another similar clinic. Most agree that patients with a high degree of invasiveness entailed in their operation should be seen by the anesthesia provider at least one day prior to surgery. But again, there may be certain extenuating circumstances that require more days preoperatively to plan, or a discussion may be had between the surgeon and anesthesiologist that obviates this need. However, this actual recommendation is, again, left up to expert opinion and judgment. So in terms of specific tests and labs, we should start by defining terms. A routine test is a test ordered in the absence of specific clinical indication or purpose. An indicated test is a test ordered for a specific clinical indication or purpose. While this seems very obvious, and it is worth noting because the summary from the 2011 ASA Task Force regarding pre-op labs is that routine pre-op labs do not make an important contribution to the process of perioperative assessment and self-management of the patient by an anesthesiologist. That is to say that testing should be individualized based on the patient's history, operation they are going to have done, the type of anesthetic they will be undergoing. So, again, tests are individualized based on the patients and what will be proceeding thereafter. So routine tests do not have a place, again, from the 2011 ASA Task Force guidelines. There is no such thing as a routine test that they expect. So that leads us to what constitutes a clinical indication. Then we have routine tests that are that I've tried to unpack. So an ECG may have a clinical indication in many patients. This one comment they would like to make in their practice guidelines is that age alone is not sufficient to mandate ECG, though they do give a nod to various institutional policies that some institutions may have set a standard for age and that those should be respected from case to case. But as far as the entire ASA group, they did not agree on even the exact age for an EKG. Other elements of the clinical history, including history of hypertension, high cholesterol, chest pain, shortness of breath, those may be more than enough to constitute ordering that test as part of the preoperative workup for the patient. A chest x-ray in and of itself is not required for any patient before an operation, just as a routine test, but cardiac disease, COPD, or smoking may push the provider to a strong consideration of ordering this test. Similarly, CBC, chemistries should follow a patient's history and again, the type of anesthetic they may be exposed to. So again, individualized care. Now, in this slide, This is somewhat busy, but the only point I want to include is a broad one, in that this column summarizes what I've already been talking about, in that there is an extremely small percentage of consultants or ASA members who consider routine EKG, chest X-ray, PFTs, H&H, coags to be required. However, there are selected patients that almost all of them can agree would be candidates for these labs. And what is important here is they've given certain review of systems or medical history elements that may point a provider towards ordering a given test. So I've highlighted EKG. What is interesting to note here is that advanced age for many of the providers actually is an indication to get an EKG, so they would consider that an indicated test. However, they could ultimately not agree on that exact age. So again, it's left to institutional policies. But a history of cardiovascular disease or respiratory disease, 97% and 74% of the consultants in the ASA task force and 98% and 74% of the members here agree that that is an appropriate indicated test in patients with this history. And you can go on down the line. These are readily available in the ASA task force guidelines. So how does this translate to the clinic? In essence, we as clinicians are responsible for a preoperative assessment to build a base for the labs and tests that should be ordered. That is, we order them ourselves, or our anesthesia colleagues may order them as well. A thorough review of systems and physical exam are crucial in defining care pathways to optimize outcome and mitigate risk in surgery. Previously unidentified health problems or worsening of previously known problems that may not have been previously recognized is a very important element of our care outside the operating room for these patients. This slide just highlights very important questions that are maybe so-called high-yield points. Cardiopulmonary system should certainly always be evaluated by the surgeons, surgery residents in clinic. Can you walk a block without pain or dyspnea? Do you have pain, chest pain or dyspnea at rest, palpitations, recent acute coronary syndrome, or invasive procedures? And then the other points speak for themselves. But these are elements in the 12-point review of systems that we should all be reviewing as part of our exam. So moving on to the rationale for preoperative cardiology consultation, the rationale is actually similar to what labs you would order or what other elements of preoperative testing you may find necessary to plan for your patient. So we want to identify undiagnosed or previously diagnosed but untreated cardiac conditions that may portend poor outcomes for a patient subjected to general anesthesia. And in those patients, we want to mitigate risk by appropriately monitoring those patients who require surgery despite their cardiac disease, or possibly even intervening prior to an elective operation. So there are certainly unintended risks of consultation to a cardiologist. Those, like any test, nothing's for free. That consultation costs you time and execution of a procedure, so you're going to have to delay your operation. It may not be an emergency, but still, nonetheless, it takes time out of that patient's life. And two, the risk in a potentially invasive procedure by the consultant is certainly present as part of the perioperative workup. And there are certainly reports of people that ultimately got cath that had outcome issues or complications from those caths that ultimately would not have made a difference in the operation. So in one study, it was estimated that 75% of cardiology clearance consultations were unjustified. Routine cardiology assessment found that only 8% of patients required further workup. And another study, 16% of patients out of 100, or 16 out of 100 with a, quote, positive cardiac history, referred to a cardiologist for risk stratification, were found to actually be high risk, and only one of these patients needed further intervention. So fortunately, there actually is a pretty good evidence-based pathway adopted by both the American Cardiology College of Cardiologists and also the American Heart Association that help guide us in a stepwise manner on when we should seek cardiology consultation. So I'm going to spend a little bit of time on this slide because I think it actually provides a really good pathway for us when we think about who really needs a cardiologist. to see them before they go under anesthesia. The first thing to identify is whether or not they have an active or unstable cardiac condition. And these conditions, which require a cardiology consultation, are listed in this first box over here. So an MI in the past 30 days, unstable and severe angina, acute or new onset or decompensated heart failure, significant cardiac arrhythmias, and severe or symptomatic valvular heart disease like aortic stenosis or mitral stenosis. So this is an easy one for all of us. If they meet any of those criteria, they should see a cardiologist before an elective surgery is undertaken. If not, though, if there's an elevated MACE risk greater than 1%, which stands for major adverse cardiac event, and that being greater than 1%, then further evaluation may be warranted. If not, then none is required. But the next question that should be asked, if they have an elevated MACE, which I should say is a risk of acute coronary syndrome, which can be calculated by either the ACS NSQIP guidelines, which I have listed a brief screenshot, but essentially the risk of cardiac complications for this scenario that I input was 0.1%. But if this is greater than 1%, or if in the cardiology risk calculator, that one could be used as well. If it's greater than 1%, then further workup may be warranted. They should then be interrogated as to whether their functional status is robust enough to undergo general anesthesia without cardiology workup. That is interrogated by asking simple questions, such as, can you take care of yourself? Can you eat and dress yourself? Can you do light work around the house, such as dusting or washing dishes? If they're able to do more than light work around the house, likely their heart is in good shape. If they're not, this may warrant further workup. And then really, if they've answered, or if they've checked out to being a high MACE risk and a high risk based on their METs they can perform at home, they should be interrogated for clinical risk factors specifically related to adverse coronary events. And these are listed in box 2 here. History of prior heart disease, compensated or prior heart failure, stroke or TIA, serum creatinine greater than 2, or diabetes. If at least 3 of these are present, then a cardiology consultation is required. If not, they can still be entertained and may at the very least be a candidate for a stress test. And based on those results, may require a cardiologist. And if I did not say it earlier, METs basically are an estimation of energy expenditure, but basically 1 kilocalorie per kilogram per hour. If you're at 1 MET a day, you're barely just functioning at a minimum, and those patients are certainly at risk for adverse cardiac outcomes. Moving on to perioperative medication. This is another element that I think comes into some question on the day of surgery, and what medications should be held or what should be continued, and what are medications that we should discuss versus unilaterally make decisions on. Similarly, what is the role for DVT prophylaxis? And then what is our role in selecting, or how should antibiotics be selected for surgical site infection prophylaxis? So with the rise of type 2 diabetes, many patients are put on oral anti-hyperglycemics. Currently the most common is metformin, which is biguanide. Certainly known to us is there is a risk of lactic acidosis in these patients. However, that risk is actually fairly small in patients with a normal GFR. There is certainly a concern for the perioperative patient with the MPO status, given that this medication may cause some alterations in blood sugar. Also, given potential extremes of blood pressure and need for IV contrast intra-op, there is also concern that the risk of lactic acidosis may be increased. So the general recommendation by the American Diabetes Association and the American Association for Clinical Endocrinology is that metformin should be held on all hospitalized patients, and really should probably be held 24 to 48 hours prior to an operation. Another oral anti-hyperglycemic classification includes the sulfonylureas and the SGL2 SGLT2 inhibitors. These should also be held 24 to 48 hours prior to surgery. And then ultimately, they in their recommendations in that glycemic control in the perioperative intraoperative period is best addressed with rapid-acting insulin and frequent glucose measurements intra-op. Another hot topic among medications is beta blockade. There was certainly heightened interest in this some years ago with the feeling that beta blocker has such good outcomes in patients with known cardiac disease. It was felt that patients that are deemed to be high risk for non-cardiac surgeries and for cardiac surgery should really be on a beta blocker before. Interestingly, or before the operation, interestingly, a 2016 Cochrane review compiled data from 36 studies evaluating those undergoing non-cardiac surgery getting beta blocker in the perioperative period. An increase in all-cause mortality and stroke was noted in this Cochrane review. However, perioperative MI risk and significant supraventricular arrhythmias were reduced. They did comment on potential weaknesses of the study, including the researchers feeling that some of the studies qualities were low to moderate, and that they were not selective in those studies that they included, that they essentially lumped, that had patients on home beta blockade versus those that were started more proximate to the actual operation. So going back in the literature somewhat, the MAVS and DIPOM studies from 2007 did show an increase in hypotension and bradycardia with no ultimate mortality benefit in routine beta blockade. The POISE study built on these two studies and showed an increase in perioperative all-cause mortality and strokes despite lowered rate of arrhythmias and MI. This study was actually very well done and got enough attention from the ACC and AHA to withdraw the recommendation for routine beta blockade in high-risk cardiac patients for non-cardiac surgery. A 2013 meta-analysis corroborated the POISE study findings. So the VA did a quality improvement study where it reviewed over 100,000 patients treated over a 6-year period. And their results somewhat contrasted the POISE study in that there was no observed increased mortality or strokes. An interesting point is those that were randomized to a placebo arm of the study who had been maintained on long-term beta blockers did not show an increase in mortality. As an aside, the lead researcher in the POISE study commented that his interpretation of the findings were that the cause for increased stroke and overall mortality was related to the hypotension incurred by the beta blockers. He's actually a pretty strong believer still in the importance of those in mitigating acute coronary syndrome risk, but did give a nod to those patients that may be at risk because of the hypotension that ensued. So luckily we have our standard of care guidelines based on evidence. Those on a long-term regimen should still be, based on class 1B studies, should be continued on their beta blockers. It is recommended certainly for paroxysmal or persistent atrial fibrillation. And in some situations, it may be reasonable to initiate in the perioperative period in those that are intermediate or high perioperative risk, although the agreement now is that we should avoid starting routine beta blockade on the day of surgery for some of the reasons I discussed. Other antihypertensives that were included include ACE inhibitors and clonidine. Based on level C evidence, there's actually no reasonable recommendation that ACE inhibitors should be routinely stopped. If there is, certainly based on clinical judgment, if patient hypotensive, you're not going to reinstitute their blood pressure medicine, but ACE inhibitors actually should be continued as soon as possible based on evidence. And then clonidine is not recommended for routine prevention of MIs or other cardiovascular complications, but we should be aware as clinicians for the risk of rebound and the need for reinstitution of that medication post-op. And other antihypertensives should be continued to maintain based on clinical judgment. The current ACA and AHA guidelines for statins is to continue them, and actually there is a known benefit based on class 1B evidence that statins reduce 30-day mortality for after non-cardiac operation. So those are really medications that, if at all possible, should be reinstituted if a patient is already on them. And then based on somewhat weaker evidence, but still kind of mid-level recommendations, perioperative initiation is reasonable in patients with at least one cardiac risk factor that were previously naive to statins for cardiac protection. Antiplatelet medication is certainly a question that comes up for us and our concern for bleeding in the perioperative period. The best thing for us is to think about patients in terms of those who have had stents and those who have not had stents before. I'm talking specifically about coronary stents, although you can make an extension to other stents for peripheral arterial disease. But certainly in a patient that had prior stents, the major concern is in-stent thrombosis leading to an acute coronary syndrome if that antiplatelet therapy is held. So the standard of care certainly from the AHA and ACC is to maintain dual antiplatelet therapy for a set duration after a stent was placed. So it is worth talking about the two main kinds of stents that there are. Bare metal stents may be maintained, or a patient may be maintained on dual antiplatelet therapy for 4 to 6 weeks, whereas drug-eluting stents really require a year of dual antiplatelet therapy. So that is generally aspirin and Plavix or some cousin of Plavix. There are a number of those out on the market. But all elective surgery in this time period with significant bleeding should be deferred based on expert opinion. And this makes sense if a patient has a more pressing need than that ultimately gets discussed. So at a bare minimum, the aspirin should be continued. However, there is certainly concern that if the Plavix is held, there could be an in-stent thrombosis. And so as much as possible for those elective cases, we should probably hold off on doing an operation if at all possible. In patients with no prior stents, there's class 3 recommendations that actually there's no benefit in those without prior known coronary disease, that they would get a significant benefit from the aspirin. So those patients, it is probably reasonable to hold aspirin preoperatively, again, if they have not had a prior coronary stenting or known cardiac disease. So there are certainly patient scenarios, specifically patients with cancer or other diseases that may be pressing, where you can't wait for an operation for a year. So ultimately, the management in the perioperative period should be a consensus of the surgeon, cardiologist, and patient. And you may need to involve other consultants, such as hematologists or others, to help guide care in those patients that do require an operation that cannot go off their dual antiplatelet therapy. So I won't speak too much about things like Coumadin and other anticoagulants, but essentially this, again, comes down to risk-reward. Patients that are on Coumadin for prophylactic purposes, that is, they have atrial fibrillation, a mechanical valve that they are trying to prevent the risk of stroke, that ultimately is going to be an individualized decision that you're going to have a discussion, or potentially have a discussion with the anesthesiologist and provider that put that patient on the blood thinner and the patient. So on to the next topic of perioperative VTE prophylaxis. I think all of us are familiar with the NSKIP guidelines of institution of Lovenox or heparin or some similar medication within 24 hours if at all possible. But should we be doing more? The answer is, in some cases, yes. First of all, I think it's important to chunk the risk, or put it into subgroups, I should say, as low risk, moderate risk, high risk, or very high risk. I will mention that there are certainly patient risk factors and different kinds of operations that are not listed here, but for the purposes of this talk, very high risk patients, for elective general surgery patients, we can think of abdominal cancer patients. Low risk patients tend to be healthy, same day, minor procedure patients with no additional risk for venous thromboembolism. And then the moderate and high risk are in the middle. with patients in older age groups or more extensive open operations or more extensive laparoscopic operations. So the risk for prophylaxis follows accordingly. For low-risk patients, early ambulation and maybe SCDs during the procedure are actually sufficient. Moderate to high-risk patients should at least receive some chemical DVT prophylaxis. For high-risk patients, a strong argument can be made that prophylaxis should be started actually prior to surgery and actually should realistically be continued for 7 to 10 days postoperatively. In the very high-risk group, all the recommendations for the high risk are basically carried to the next level, where a strong consideration for starting DVT prophylaxis 2 to 12 hours before an operation and continuing it for at least 7 to 10 days, with a strong consideration for continuation of that prophylactic dose for 4 weeks. Those recommendations are endorsed by all the following cancer societies based on evidence which I will show here. The cancer risk for the venous thromboembolism risk for cancer patients is noted to be 2 times higher than in non-cancer matched cohorts based on a 2005 study in the Annals of Oncology. And if that thromboembolism occurs, it is 3 times more likely to be fatal. There are also studies that report on the persistent hypercoagulability of these patients, even up to 4 weeks post-op. So this actually came up on CSAP too as a question recently, but the recommendation is, or a strong consideration for 1 month of DVT prophylaxis after an operation is done, given the known risk for VTE after major abdominal pelvic operations for cancer, and also those with residual cancer. While it would take too long to go through every organ system and talk about every antibiotic for every system, I do want to give a brief outline for what the goal is. There was a task force some years ago that was presented to decrease the overall surgical site infection by set quantity, which I believe is 25%. That was certainly a goal that was embarked upon, and so multiple measures were instituted to try to decrease surgical site infections. We are certainly familiar with antibiotics, but all the preoperative elements that we take as routine now, including hair clipping, normothermia, trying to reduce the exposure of the patients if at all possible. These are all meant to try to reduce surgical site infection. And again, this is led by the National Surgical Quality Improvement Project. In general, we should remember that empiric coverage should be directed towards those organisms most likely to cause infection as a function of the organ system involved in an operation. So this is a snapshot of some of those perioperative bundled measures. Prophylactic antibiotics should be received within 1 hour prior to incision. The patient should have appropriate hair removal. Perioperative temperature management is very important. Good blood glucose control is important as well. This is not an exhaustive or comprehensive list, but it does show that the appropriateness and timing of antibiotics is important in the bundled reduction of surgical site infections. So this does lead us in the transition of care bundles, which I think for our purposes may be thought of as a set of individual steps or interventions which may work in concert for a defined goal. In regards to surgery, these may include, but are not limited to, the bundles to reduce SSI, bundles to reduce length of stay, bundles to decrease ventilator-associated pneumonia. Enhanced recovery after surgery programs are now relatively commonplace. In fact, it is not uncommon at all to have somebody that is like a care coordinator that specializes in ERAS programs for different specialties. The overall intent is to optimize perioperative care of patients with the goal of providing postoperative outcomes with potentially multiple endpoints. Specifically for surgical patients, the endpoints can include pain, early ambulation, time to discharge, time to return to bowel function, or patient satisfaction. and again, the common elements of care bundles are listed. There are preoperative measures, intraoperative measures, and postoperative measures with many, if not most, of these care bundles. The goal, again, being bringing together evidence-based medical techniques or other elements of the care plan in a bundled package to ultimately provide enhanced recovery. So one bundle that is prototypical for other ERAS initiatives is the colorectal fast-track surgery prototype. Phrase was coined in the 2000s, and there was a pathway that was initially published in Lancet in 2008. There, of course, are many iterations of fast-track surgery in the literature now. I've included this just as a reference point. This is not meant to be the sanctioned fast-track surgery bundle, but it is to illustrate that there are preoperative measures, which are taken, intraoperative measures, and then the next slide there will be postoperative measures. And these may be, depending on the environment in the institution, they may be more or less rigid or meticulous, but overall it does bring together evidence-based strategies to try to produce overall improved outcomes. You can see there's some obvious things here, and there may be some things that you would not expect, but overall it brings together different elements into the bundles. And then you go to post-op day 1, post-op day 2, and there are initiatives for advancement of diet, removal of Foley catheters, discontinuation of antibiotics, etc. So do they work? Should we even have care bundles? The answer is overwhelmingly yes when they're executed well. Again, to take colorectal surgery as one of many options, a meta-analysis of 16 studies to assess reduction in SSIs in colorectal surgery as a function of the care bundles was assessed. Overall, you are half as likely to develop an SSI based on this meta-analysis of randomized control trials and cohort studies if you were a patient that received bundled care versus those who did not. So I could spend hours talking about the success of care bundles, but that would take too much time. I think what is, to be on my soapbox just for 2 seconds, is that when patients don't have outcomes that are as robust as that, and they may not be so significant as a 200% improvement in whatever your baseline was prior to instituting bundle, but those bundles that are not met with the same success or similar success, I think you have to go back and review why. And I actually was able to find an article from 2015 in the International World Journal that opined on some of these possible limitations to good bundle implementation. So they thought at least it would be worthwhile to review compliance. This was strongly hinting at the surgeons and how much they bought into a given bundle and if they thought it was necessary or not. Another option that they felt was important was incorporation of checklists or bundles into the informed consent. I think this is really important, and that's to have robust surveillance methods with agreed upon definitions so you can actually track what is an improvement and what is not. 4 is also very important. There's continued updating of evidence-based guidelines. So as studies come out that are leading the field in whatever area they may be, I think it is important to incorporate these to improve and make your bundles more robust. Certainly behavior change by the team leader was felt to be lacking in some situations and why these bundles were not adopted. They also felt it was important to keep logs of near misses to learn from those. And certainly one thing that frequently limits the implementation of bundles, it may not ultimately kill them, but it is an impediment, is the clear communication of new implementation strategies and also incorporating patient awareness into the bundles. So from my talk, I think what we can take from this is a good operation and good clinical outcomes start in the clinic. Literature could and can and should be used, not just in deciding what operation should be done or how to execute an operation or what the best strategy is, but actually in the planning of an operation. And that care bundles are really just a set of good evidence-based recommendations rolled into one for best patient outcomes. So with that, I will be happy to answer any questions.
John?
Yes.
That was pretty good. The interesting thing that happened historically is everybody used to get admitted to the hospital. And we had the time to spend an hour talking to our patients at that point and finding things that we didn't necessarily find in the clinic. And now with outpatient surgery, it's kind of like a limited 15 to 20 minutes in the clinic. And it seems like we're rushed and we miss things a lot of the times. And then we're depending upon our anesthesia colleagues to pick it up. One of the things that really helped was about 20 years ago, general surgery started having a pre-op conference. So that we go over on Fridays or on Wednesdays the cases that are going to undergo an operation the next week. And that's where we kind of catch things. But we still miss things. And I think part of it has to do with our population that we're dealing with too, who have had a major operation, but they don't know exactly what was removed or some of the other things or what drugs they're taking. I think maybe the electronic medical record has helped us in some of those ways.
Right, and I think another thing to add on to that, and certainly make a good discussion on things to mitigate some of those misses, but that is one. And then another thing I think is the addition of mid-level providers in the outpatient clinics. I think that makes a difference too. Is definitely a helpful adjunct.
What are the recommendations for people? We see people that have had a stent, coronary artery stent, 1 year ago, 5 years ago, 10 years ago. They're walking around and they're asymptomatic. And we have been getting cardiology consults on those people. Because a lot of times the anesthesiologist wants to know, has the patient had a recent stress test?
Yeah, I think on that I would probably go back to, see if I can get back up to it in a somewhat, so based on the recommendations of their the guys that are in charge of this stuff, the cardiologists, the AHA, the American College of Cardiology, they have pretty good evidence that for drug-eluting stents, you need to be on for a year dual antiplatelet therapy. Probably most of those patients, there's probably a few that just maintain those just because it kind of gets left to run over and the cardiologist keeps refilling it. But realistically, they probably can come off one of those antiplatelet medications after that 12-month period. And then I would say that ultimately, if the anesthesiologist that you're working with doesn't want to put somebody to sleep, they're not going to, unless they unless they feel satisfied that they're doing the best care for the patient. But realistically, I found this to be a really helpful pathway for me. And you can say, I'm not trying to be difficult, but if you want an evaluation by a cardiologist, then we certainly can do it, but there's an evidence-based pathway for obtaining cardiology consultation, and really you can follow these things down. It actually answers every question there. So the stent 10 years ago, if